Everybody, and welcome our speaker today, Dr. Jason Simmons. He's an assistant professor in the infectious disease division here at UW, and today he will give us this year's ID for Allergists talk, and he'll be talking about Hansen's disease. So looking forward to it. Thank you.
Great. Well, good morning, everybody. Is my audio okay?
Sounds good to me.
Great. So it's a pleasure to be with you here. I appreciate the invite. As Anya said, I'm Jason Simmons. My clinical roles are here at Harborview. I'm the director of the Infectious Diseases Clinic, as well as the Hansen's Disease Clinic, which will be relevant today. The word of the day, I think for CME purposes, was infectious. No financial disclosures to make. So it's the first time I've given this lecture. I hope it's of interest. I looked at topics from years past, and I think John Lynch gave it for a number of years with topics like measles and superbugs. And then in the COVID years, he was giving essentially exclusively COVID updates. And then Dr. Danareddy really covered a potpourri of topics last year, including novel antimicrobial treatments. So I decided to do something a little bit different. I hope that's of interest to you all. And we're going to discuss various aspects of Hansen's disease. So why would we focus on Hansen's disease? Well, one, I think people generally are interested in this uncommon infection. It's something that we don't think about every day, but mostly thinking about overlaps between infectious disease and allergy. Hansen's disease is really an expose of a real differences in host immunity in terms of the disease manifestations. And then I wanted to move into what we deal with a lot in clinic, which are these immunologic reactions that are common in Hansen's disease and how there may be parallels to other paradoxical reactions we see in treating infectious diseases. So I hope that that's of interest. Objectives today. By the end of the lecture, I think you'll be able to name 2 organisms that cause leprosy, otherwise known as Hansen's disease, and then build some familiarity with some basics in epidemiology and transmission. And then be able to describe Hansen's disease using a lens of host immunity. And then also name 2 of the main immunologic reactions we see in Hansen's disease, and how we may be able to use those to better understand paradoxical immune reactions to other infectious diseases. And then finally, a couple slides on dapsone hypersensitivity syndrome. So one of the major questions I get when friends or family learn that I treat patients with leprosy or Hansen's disease is that still a thing? I thought that was a biblical disease, and certainly Mycobacterium leprae has been co-evolving with humans for many thousands of years. The earliest evidence of disease in humans is seen in the skeletal record from 2000 BCE, and then we've isolated genomes from as early as 80 to 240 AD. Interestingly, the biblical reference, it's probably largely a misnomer. So it comes from this Hebrew term zarat. I'm sure I'm not pronouncing that correctly, but that was a term broadly to refer to skin diseases. The term leprae was introduced at the Greek translation of the Old Testament. Lepra was also a very generic term for skin disease, which was ironic because the Greeks actually had a specific term for leprosy, which was elephantiasis graecorum. Nonetheless, really, since these times, there's been, to this day, there's been this association between sin or uncleanliness and disease, which unfortunately we see as a stigma manifestation in our patients today. Fast forward to the 1870s, so Dr. Gerhard Hansen was a Norwegian physician who really dedicated his life. He did not think this was either a disease of sin, as was still commonly held, or a genetic or heritable disease, as others thought, and that this was truly an infectious disease. This was early in the era of germ theory. And he spent many years optimizing microscopy and staining techniques and did visualize the bacterium. Now, this was 20 years before Koch identified Mycobacterium tuberculosis and presented his postulates of disease transmission. So the term Hansen's disease is what we prefer to use today for leprosy, really to address the stigma that's associated with leprosy. Unfortunately, Dr. Hansen really kind of demonstrate this was a transmissible disease, uh, exposed patient material, infectious material into an unknowing patient. And so whether we should really be honoring his legacy is actually debated. So moving on to some disease transmission, this is mostly for fun. Which of the following is false about the transmission of Mycobacterium leprae? A, autochthonous transmission may arise from nine-banded armadillos. B, an M. leprae reservoir among red squirrels resulted from human to squirrel transmission. Or C, endemic transmission is seen among chimpanzees. The transmission risk among humans is very low. In fact, 90% of humans are resistant. Or E, that these are all true statements. So this is mostly for fun. These are all true. So there's a lot that we don't understand about the pathogenesis and transmission of Hansen's disease. This is largely because the bacterium can't be cultivated in culture, and there's not great microbiologic techniques to detect infection, especially early after exposure. But nonetheless, it's commonly held that it requires really prolonged person-to-person transmission through respiratory droplets. And the majority of cases in the United States are a result of migration. We think most of those were exposure that occurred before immigration to the U.S., although there's some role for autochthonous transmission among populations as well, like within households. You may have heard, it's been a couple years now, Hansen's disease really made the national news cycle because there were a larger number than expected cases in Florida. And this was particularly interesting because many of these patients had no travel history and built the argument there's more autochthonous transmission. Going back, there's no evidence in the New World that there was any Hansen's disease until 1750 in New Orleans. The bacteria has actually been cultivated in armadillos as an animal model and susceptible host. And it's over 20% of actually wild armadillos are known to be infected with the organism. And in 2011, investigators were able to use whole genome sequencing to link the strains that were in armadillos with human cases, and exposure to armadillos is actually a known risk factor for transmission. So this is certainly one animal reservoir that potentially plays an important role for transmission. But there are other animals that are able to harbor the infection. So recently, there were studies in chimpanzees, an interesting study. These chimps were under video surveillance for a separate study, and some were caught on camera as having these lesions that were really consistent with lepromatous leprosy. And so a separate study, they went back to these colonies and collected droppings under those trees and were able to identify the organism. Similarly, there was a study into red squirrels in Scotland back in 2014. There were declining squirrel populations, and when they were trying to investigate why that was happening, they noticed some squirrels had this dermatitis of ears, eyelids, and snouts. And in fact, they were able to identify not Mycobacterium leprae, but Mycobacterium lepromatosis, which I'll talk about next, in these squirrels with these disease manifestations. That led to follow-up studies throughout the British Isles, including in Brownsea Island here. And what's interesting is they identified both lepromatosis and leprae circulating and being maintained in these squirrel populations. And when they looked at those genomes and compared them with genomes from exhumed bodies from the medieval ages, they were able to confirm that the squirrels actually probably acquired the infection from humans at that time, and it's been maintained in those populations since. There's no good evidence that transmission is occurring from the squirrels to humans, however. So the etiology of Hansen's disease is both Mycobacterium leprae as well as lepromatosis. These are related species, about 91% sequence homology. Lepromatosis was only identified in 2008. It gets its name because it tended to cause more severe disease manifestations along the lepromatous leprosy spectrum. And it initially was thought to be largely restricted to the Americas. In fact, by genomes, they thought that this bacteria was introduced in migrant populations over the land bridge and established in the New World. But it's since been identified throughout the world. And a general comment about the evolution of these species. So they share only about 50% of coding sequences with Mycobacterium leprae. So there's this big genetic drop-off in the evolution of these species through this reductive evolution. You can see in this upset plot, these are coding sequences that are overlapped. So they share over 1,300 coding genes with Mycobacterium tuberculosis. And then when you look at lepromatosis and leprae, there's very few unique genes actually in these species. And so this reductive evolution means a couple things. One is the circulating strains of Mycobacterium leprae. There's very little genetic diversity among in these transmission cycles in humans. And then two is these are definitely obligate intercellular pathogens. We've not been able to replenish the key ingredients for replication. Other comments on the microbiology is the bacteria have this tropism for cool areas. That's probably why they replicate in armadillos. We can also propagate them in mouse foot pads to a limited extent in immunocompetent mice. But in athymic nude mice, they propagate quite a bit more in these mouse foot pads that are cool. And so one place that they proliferate in humans is within peripheral nerves, so these areas that are near the skin surface and thought to be cooler. A couple words on epidemiology. One reason that we don't know much about leprosy, and at least in the lay population, even among physicians, is the WHO met their elimination goal. So the goal was to reduce prevalence to less than 1 case per 10,000 within endemic countries. And with the institution of multi-drug therapy, or MDT, in the early 1980s, they met this goal by 2011. The prevalence was 0.37, so far below that one. Nonetheless, there remains a burden of disease, particularly in India, Southeast Asia, Brazil. This is the 2020 WHO map that looks largely the same today, where you can see over 10,000 new cases in these areas. What's probably more relevant to the US is if you look at the data in terms of incident rates, so cases per million population, you can see India and Brazil here at the top of the list, certainly a big part of the global burden. But if you look at nations like Micronesia, Marshall Islands, those incident rates are extreme compared to even the most prevalent areas. And this is where we are seeing most of our cases in Seattle is from these Pacific Islands, patients who are exposed likely in the Pacific Islands. Within the United States, it's not many cases a year. It hovers around 200 cases per year. Most of those are seen in Hawaii, California, the Houston area, Louisiana, Florida, New York. Washington really has an intermediate number of cases per year. And this is data that we recently submitted. It's not actually a reportable condition in Washington state, but we do report cases to the National Hansen's Disease Program. And you can see a majority of cases each year are really coming from these Pacific Islands. Most cases are in Western Washington and King County and neighboring counties. So moving on to host immunity in the disease. So a couple main points are, it's believed over 90% of humans are actually resistant. This comes from data with follow-up of household contacts from infectious cases. And after that exposure, even among higher risk exposure from the multibacillary form of the disease, there's various pathways that are seen clinically. So one is just no infection at all in over 90% of people. We don't really know if that means that the bacteria never establishes and is immediately cleared, like by innate immune mechanisms, or if a proportion of these individuals have established infection, but it's just contained and remains asymptomatic for life. This is kind of like Mycobacterium tuberculosis and other mycobacterial infections. But a proportion, so less than 10% of patients will go on to clinical disease manifestations. And this is really where there's various host responses that determines the disease pattern. I'd mentioned there's very little genetic diversity in the actual bacterium. We don't think that that diversity plays an important role in these disease manifestations, and it's really all about the host. And so we'll talk about the various categorizations: paucibacillary, multibacillary, lepromatous, and tuberculoid. And then finally, among these different diseases patterns, there are these immune reactions that are very prevalent in treating Hansen's disease, and it gives us a window into better understanding paradoxical reactions in general. So the disease classifications, the WHO keeps this really simple. The goal is to allow community healthcare workers to use readily available clinical findings in order to institute appropriate treatment. So they separated into paucibacillary disease and multibacillary disease. The paucibacillary disease just means you have up to 5 skin lesions. And if you do these slit skin smears where you scrape under, we usually do 6 sites: elbows, knees, ears, and you can't find any AFB positive organisms, that would be consistent with paucibacillary disease, whereas multibacillary disease is positive slit smears or 6 or more lesions. Now, this Ridley-Jopling classification was described in the 1960s, and it immunologically is more interesting. It really gives a spectrum of Hansen's disease across an immunologic axis. And so that's where we talk about tuberculoid on one pole and lepromatous on the other pole. So discussing tuberculoid leprosy. So this is the end of the spectrum that really has what's thought to be a robust and effective cell-mediated immunity. So a Th1 skewed immunity. The histopathology will show really well-organized granulomas and very few bacteria. You could see maybe 1 or 2 AFB positive forms on the phyte staining below. But this granulomatous response effectively controls bacterial replication and limits the extent of the disease, usually to just a few lesions. Clinically, what we see is within those lesions, you can see these big patches, hypopigmented patches in these areas. As patients are insensate, usually within the margins of those lesions, and it's not because that granulomatous response, the antigens and the bacteria are on these Schwann cells of nerves, and that effective granulomatous response is destroying those cutaneous nerves, leading to insensate lesions. If you look at the skin itself, there's really a Th1 response that predominates. And so high levels of interferon gamma, IL-2, and then also Th17 cells. So again, skewing more towards a pro-inflammatory immune response where you have high IL-17, IL-6, and then also NKT cells that are expressing interferon gamma. All of these cytokines are priming the macrophages, which contain the bacteria, into microbicidal pathways. So they're activating these macrophages effectively to control bacterial replication. One feature in this poll is a positive Mitsuda reaction or a lepromin test. So skin testing isn't used to diagnose Hansen's disease because the results are quite variable. It can be helpful. We don't use it in the US, but it can be helpful to better classify the disease. And so on this poll, you do get a positive skin test effectively because you have this good Th1 immunity and delayed hypersensitivity reaction. And it works just like a TST skin test for TB. The antigens that are used can be variable across sites, but it's either heat-killed bacteria or purified protein like in PPD. moving, so that's one, the tuberculoid pole of the disease. Moving towards the other pole, the lepromatous pole, it's a completely different disease. This is when you completely fail to control bacterial replication and the bacteria can disseminate. And so this includes borderline lepromatous and lepromatous leprosy. You get a stepwise sort of progression of an inability to mount a granulomatous response or an organized granulomatous response. And so in lepromatous leprosy, these skin lesions all the way down to the dermis are filled with these foamy macrophages, histiocytes, and they contain globi of mats and sheets of bacteria. Clinically, there's a number of patterns. You get alopecia, matosis, loss of eyebrows and eyelids. You tend to get much more nodular eruptions, not the plaques. And those nodules are just usually teeming with bacteria, and they are cool areas. So not just the skin, but ears. There's a predilection to have these big nodules. Um, the the disease is characterized immunologically with essentially anergy. So some people refer to split anergy with Hansen's disease. It's split because the tuberculoid pole is not anergic, whereas this pole is. And it's pathogen specific. So these patients aren't necessarily allergic to a TB skin test, although they can be. A Th2 response really dominates in this poll, so high IL-4 and immunosuppressive cytokines like IL-10 and TGF-beta. And then there's also this imbalance with regulatory T cells. So usually higher circulating levels of regulatory T cells and lower Th17. So again, this skews the host immunity away from control and pro-inflammatory responses into more of a quiescent tolerant spectrum. And so there's lower levels of interferon gamma, TNF alpha, and IL-2. A consequence of all of this is macrophage activation towards a quiescent macrophage that lacks the microbicidal killing pathways. You get this disorganized granulomatous response I mentioned, and you would get a negative Mitsuda reaction if you do one. Interestingly, if you poke at these skin lesions, they are not insensate. You actually are preserving the cutaneous nerves in these areas because you don't have an effective microbicidal inflammatory reaction. And so looking at that spectrum as a whole, again, on the tuberculoid pole, you have good bacterial control, organized granulomatous response, and then you lose that as you march and progress towards lepromatous or disseminated disease, where you have this Th2, TGF-beta, T regulatory cell, and then these sheets of foamy macrophages. So to illustrate kind of these disease spectrums, I picked a few cases to share. So this first one is a 30-year-old from Micronesia, from the island of Kosrae. She unfortunately had a history of metastatic choriocarcinoma. And that history included chemotherapy she received between November 2020 to April 2021. And it was actually a month after she completed, or a few weeks after she completed chemotherapy, she was admitted with a febrile illness. We didn't know her at this point. We weren't referred, she wasn't referred to our clinic for a year later. So just looking at her pictures, we were able to kind of put the story together. And you can see by the time she was admitted in early May, she was getting count recovery. And at that time, it's the first time she had noticed, and I think the care team had noticed this large plaque on her back that had been asymptomatic, not noticed before. Within a week, that plaque became really angry and inflamed, so raised, warm, painful. She went on to have a biopsy at that point in time, and the biopsy showed a granulomatous or histiocytic infiltrate. There were no microorganisms, no fungal stains, no AFB stains that were positive, and negative PCRs. So she really didn't have much follow-up over the next year for that skin plaque. And she went on to receive an immune checkpoint inhibitor, pembrolizumab, she took for over a year. She ended up in our clinic because I think an e-consult from dermatology had looked back at this pathology, had considered Hansen's disease, and sent her to us. And when we met her, this plaque was really quiet. It had not been expanding, was essentially totally asymptomatic. And so what was going on here, we had a couple considerations. Certainly one is her immune response had been controlling Mycobacterium leprae throughout her life. Her exposure was probably 8 or 10 years before. She'd been living in this country some time. Um, and only with chemotherapy did that host immunity break down, and she started having bacterial replication and then this plaque that was enlarging. And then upon withdrawal or stopping the chemotherapy, she ultimately had, reconstitution of her host immunity that contained and restricted this. There was very few bacteria that were actually seen at the biopsy at that time. The other consideration is that what role did these immune checkpoint inhibitors play in her clinical course? And so pembrolizumab and other immune checkpoint inhibitors are proposed to play a role in controlling kind of these more chronic intracellular infections that their manifestation is due to a lack of macrophage activation and killing, or a lack of an inflammatory T cell response. And I think it's possible in her case that if you look at the schematic, this PD-1 pathway is going to skew your inflammatory response more towards a Th2 or quiescent or homeostatic response, and allow bacterial persistence in the macrophages, and essentially potentiating that foamy macrophage phenotype. If you block this and that you sort of restore Th17 and then skewing the immune response towards a Th1 response, you then activate those macrophages to lead to bacterial killing. So it's possible that by using these biologics that block the PD-1 pathway, you may better restrict bacterial control, and that's possibly what was going on with her. I'm actually not convinced we needed to treat her at all. We did offer her, she got over a year of therapy and is doing well today. A caution using these immune checkpoint inhibitors. So there's good data, at least in tuberculosis, that while the idea is the same, you want a competent immune response to restrict bacterial replication. In a mouse model, if you use PD-1 knockout animals, those bacteria actually are highly susceptible to tuberculosis, and it's not for a lack of inflammation. They have profound inflammation, but it's actually likely a immunopathologic outcome. So they have so much necrosis in their lungs that the outcomes are poor. And in some cases, reports of PD-1 in latent TB, there's been progression to tuberculosis as well. So that's the disease spectrum, kind of characterizing the various immune responses. Moving on towards Hansen's disease immune reactions. So there's really two main immune reactions that we refer to: type 1 and type 2. They're both quite common. So type 1 reactions tend to happen most in the borderline phase. I didn't talk a lot about these intermediate phases in terms of the immune response, but the borderline disease is characterized by instability. So these patients tend to migrate towards one pole or another with time, and more migrate towards the lepromatous pole. It's also unstable because during those immune shifts, as the immune response is changing, you can get these sudden inflammatory reactions, and type 1 happens right in the middle of the spectrum. Type 2 reactions, which are otherwise known as erythema nodosum leprosum, are much more at the lepromatous end of the spectrum, and up to 50% of patients get these. So we'll talk about both these immune reactions, mostly type 1. And as a clinical example, this was a 23-year-old from Samoa. She'd had a known large, kind of like the last patient, a large skin plaque that had just grown over 4 years, but really was asymptomatic otherwise, and she didn't seek care for it. And then during her first pregnancy, she developed one more plaque on her left arm, and then delivered her baby December of 2020. And then within a few weeks of delivery, she developed robust inflammation in these existing plaques on the back, the arm, and then a couple new plaques that became red on her face, and a couple other sites. So she underwent biopsy of the back plaque, and it showed a robust granulomatous response, but again, no organisms seen. So this is really classic for what we call an upgrading reaction or a reversal reaction. These are triggered by M. leprae antigens, usually within macrophages or Schwann cells. Sometimes they occur in patients who've already been treated, and so these reactions can raise alarm for relapse. Usually they happen closer to the end of treatment when relapse is unlikely. But it is a confusing point because the clinical symptoms can be similar. But like you saw in those pictures, you tend to get inflammatory effects within skin lesions that were pre-existing, and it's rare to get systemic symptoms. It's a known phenomenon to see this commonly in the postpartum period. So during the second and third trimester of pregnancy, there's higher levels of T regulatory cells, and we think that that has a relevance to reversal reaction. After delivery, that shifts more towards a Th17 phenotype, and you can get these sudden inflammatory reactions occurring in that window. What's interesting is one feature that might be protective for reversal reactions is soil helminth co-infection. So that's been shown in studies in Nepal, perhaps because those helminths are skewing the immune response towards an anti-inflammatory Th2, I should say, immune profile. There are SNPs that are associated with reversal reaction. This one in LRRK2 was identified with a genome-wide association study and is of interest because the same gene has been identified as a risk factor for Crohn's disease and these hyperinflammatory granulomatous responses that are really inappropriate in the case of Crohn's. We use corticosteroids as the mainstay of treatment. Methotrexate may be effective as well. I wanted to take reversal reactions, or these upgrading reactions, as an opportunity to understand whether the immune mechanisms are relevant to other immune reactions seen in other infectious diseases. Sometimes we call this paradoxical reactions. Sometimes we call it immune reconstitution inflammatory syndrome. But these upgrading reactions, a general feature, I don't think they're all the same disease, but a general feature is you get worsening tissue pathology, skin lesions in this case, but there could be lung lesions in TB or inflamed lymph nodes. But these tend to not be culture positive. So it's not due to a lack of bacterial control. It's purely an over exuberant host response. We see these paradoxical reactions both in HIV associated as well as non-HIV associated iris syndromes. And then some examples of pathogens, we see this a lot in TB, but also other non-tuberculous mycobacteria. Cryptococcal meningitis, there's one that has a different name, post-infectious inflammatory response syndrome. This really characterized non-HIV cryptococcal meningitis, so it's a smaller subset, but the disease manifestations can be profound and prolonged. And then you could argue pneumococcal meningitis has a similar phenotype. So like in Hansen's disease, one feature is that it may be treatment actually is precipitating these reactions, and what's likely going on is you have some anergic state to begin with. That's why the infection had been progressing in these patients. And then as soon as you treat with antimicrobial therapy, you really have a novel repertoire of antigens as you're getting bacterial killing. So those may be innate ligands like TLR ligands. It may be novel antigen presentation for T and B cells sensitization. And then a consequence of that is you may reverse a macrophage polarization state from a quiescent M2 to a more inflammatory M1 state. Some schematics to explain this. So kind of not thinking about HIV-associated iris. I think it's quite clear as you're getting the reconstitution of T cells that were just frankly absent. There, you know, it's more clear what's going on immunologically, where you have a high Th1 and M1 macrophage phenotype and high levels of inflammation. If you look at a couple subtypes using you know, a metric of pathogen clearance here on the left, and then levels of inflammation on the right, this cryptococcal non-HIV inflammatory response syndrome is characterized by an abundance of antigens. And while you have effective T cell priming and Th1 responses, so pro-inflammatory responses, it's not equating to a macrophage that's able to kill these fungi intercellularly. So it's not activating these macrophages. So you have this disconnect between the T cell and macrophage priming. TB meningitis we'll talk about next. It tends to be a real balance between a pro-inflammatory Th1 profile and then an incomplete activation of macrophages. Nonetheless, you do get these inflammatory reactions, and they can be fatal when they're in the brain, and you don't have the ability to handle that edema that's created. Can lead to prolonged neurologic sequelae and death. So why do we care about these paradoxical reactions? Well, one example is by understanding that non-HIV cryptococcal meningitis, looking at the CSF profiles of these patients, some investigators saw a lot of parallels to the progressive inflammatory form of multiple sclerosis, and were able to identify biomarkers that are helpful now to potentially helpful to identify these MS patients that might respond to different therapies. But I think the best example, and I think hopefully will be of interest to this crowd, is a story about the leukotriene pathway in TB meningitis. And so David Tobin and Lalita Ramakrishnan, this beautiful sort of bench to bedside story of being they were using the zebrafish as a TB model, sort of an Marinum model to understand TB pathogenesis. And they had a hypothesis looking at SNPs with an LTA4H. You all may be able to teach me more about these pathways than I can teach you, but LTA4 hydrolase is the enzyme that metabolizes leukotriene A4 into B4, which has more of a pro-inflammatory effect, whereas a different hydrolase would metabolize it to A4 that has more of an anti-inflammatory and pro-resolving phenotype. And so the investigators had a hypothesis that these SNPs in LTA4H that impacted the gene expression really led to a Goldilocks phenomenon. If you had LTA4H deficiency, that led to an inability to generate sufficient TNF levels, and that led to that led to uncontrolled bacterial growth within macrophages, necrosis, and dissemination. On the other hand, if you had excess, so a hyper expression of LTA4, you may have an excess of TNF, which while it might control bacterial replication, it could lead to more excess cell death in macrophages. And as we know, TB can actually grow extracellular, does so well in these caseating necrotic lesions, and that itself could then lead to dissemination. So they worked that out actually, and were able to find in the zebrafish model, it worked out very cleanly to confirm that hypothesis. But they went back to data from this Vietnamese TB cohort where genotyping was available, and they looked at the human SNP that led to LTA4H deficiency or excess. And what you can see is these are the CSF white blood cell profiles. The homozygous CC SNP leads to a lower amount of CSF neutrophils, whereas the homozygous recessive TT leads to this hyperinflammatory response. If you look at disease outcomes, so these are survival curves in this meningitis cohort, and you can see there's like over 180 patients here. that both the homozygotes do poorly. So, potentially an inadequate or an over exuberant immune response leads to death. We know that that we're supposed to treat patients with TB meningitis with dexamethasone. That was shown actually by these same investigators in 2004. There's a mortality benefit overall by exposing individuals to dexamethasone. But the investigators in this LTA4H study went back to look at the genotypes and then stratified their exposures, either those that got steroids and those that did not. And they see this really striking phenotype. So among the hyper-inflammatory cases, if they did not get steroids, they did poorly. They had bad survival. Whereas the hypo-inflammatory, they essentially did what they did overall. There was not much of a change. If you give steroids to the hyper-inflammatory cases, that leads to 100% survival. Really, really striking. These are the patients we should be giving steroids to. But if you give steroids to those who are already mounting sufficient, CNS inflammation to control bacterial replication, if you gave those steroids, they did worse. And so this is a great example of potentially what personalized medicine could do if we could stratify these individuals at the bedside to know whether we could give them steroids or not. That could lead to better outcomes. And so I think really understanding what's driving these paradoxical reactions and mechanistically can lead to these biomarkers that could help us clinically quite a bit. A couple slides on dapsone hypersensitivity syndrome. Again, you all may be more familiar with this than we are, but dapsone's been used to treat Hansen's disease since the 1940s. There's something that was referred to as the miracle at Carville, where patients that were institutionalized, they assumed for the rest of their life, because there was no cure for Hansen's disease, suddenly got better and were able to be discharged from these facilities, not just in Louisiana, but worldwide. And it was used as monotherapy for years for Hansen's disease. From the WHO regimen alone, there was over 16 million people exposed to dapsone. And then, of course, many more due to other inflammatory conditions and malaria prophylaxis. Dapsone hypersensitivity syndrome was described back in 1949 originally as a syndrome, usually 5 to 6 weeks after exposure, where you get high fevers, a septic-like picture, rash, lymphadenopathy, often hepatitis. Its prevalence is about 1.4%. In its case fatality rate actually is upward of 10%. In 2013, this syndrome was linked to a susceptibility locus at HLA-B 1301. That allele frequency varies quite a bit across populations, between 0 and 28%, more common in Asian and Southeast Asian populations. The odds ratio, if you have this SNP, is a 20-fold increased risk for dapsone hypersensitivity syndrome. Again, highest risk for the syndrome in Asian populations. Like HLA-B 1502 and 5701 for SJS from carbamazepine or abacavir-induced hypersensitivity syndrome, there's a role for screening that's probably not cost effective across these global communities that are exposed to the WHO regimen, but an option in resource settings. And the pathogenesis, of course, it's more complicated than simply this allele. There's an interaction between the MHC1, the dapsone or its metabolite in the T cell interaction. And so looking at that synapse, dapsone has been shown with docking studies to fit well into this MHC1 T cell. So it can be attached to this peptide, or a metabolite might bind to a peptide intracellularly and then be presented on MHC1. The end result is these pronounced pro-inflammatory responses that leads to the syndrome. So the last few slides are on type 2 reactions. So I just talked about type 1 reactions, or these upgrading reactions, pro-inflammatory reactions. and the parallel with paradoxical reactions. Type 2 reactions are very different. So this is the biggest challenge clinically to manage. And to illustrate it, I've chosen this case. It's a 48-year-old Marshallese man. He'd been in the US for 9 years and then was aware of a rash that had slowly been progressing, started on his left arm, but throughout his whole body, and nodular lesions for the most part. Did not seek medical care. He had no health insurance. But then he went to the emergency room when he had a month-long course of really this rash getting much worse in his arms and developing these big necrotic lesions. So in the ER, they actually were worried about Louis maligna, so secondary syphilis. That was in part because he had a biopsy of these lesions that showed some forms that were concerning for treponemes. Nonetheless, fast forward, his workup and that biopsy showed a big neutrophilic infiltrate, a lymphohistiocytic infiltrate, and then abundant AFB forms, fight positive, and a positive PCR. So this is what we call erythema nodosum leprosum, or ENL. And in its mildest form, it tends to be limited to skin lesions, usually a few nodules that are tender. And then in the extreme form, it can cause these massive necrotic lesions, almost a vasculitis picture, and then it can involve other organs, including eyes, so uveitis, arthritis, orchitis, neuritis. In fact, this is a major driver of nerve function impairment seen in Hansen's disease. They used to think it caused a glomerulonephritis. It's much more likely it leads to amyloid deposition and can cause kidney dysfunction, and then hepatitis. We don't really understand what drives this because the histopathology, the circulating cellular and cytokine response isn't always consistent. So usually there are neutrophilic infiltrates, and there's often this paniculitis like erythema nodosum where you have neutrophils in the subcutaneous fat that leads to these large tender nodules. And then invariably, I mean, not invariably, you can get a vasculitis, so this necrotizing vasculitis. In its most extreme form, you can get Lucio's phenomenon where you get thrombosis of those cutaneous vessels and can lead to really widespread, pronounced necrotic lesions that are often fatal. The etiology, as I mentioned, is not fully understood. We just have a general sense about oftentimes there's neutrophil infiltrates. It was once thought to be an immune complex mediated disease, a type 3 hypersensitivity reaction. And that was based on some of these lesions being able to identify complement and immune complexes. But those aren't always present, and whether that's just a consequence versus driving the disease is not clear. And then even the vasculitis component in some studies is no different when you compare cases of ENL with lepromatous leprosy. The circulating immune profile patterns have suggested that there's lower CD4 positive T regulatory cells, a higher CD4 to CD8 ratio, and then high levels of plasmablasts. And so an antibody is thought to maybe play a role in this immune reaction. In the circulation, you often see high levels of pro-inflammatory cytokines, so TNF, IL-6. Again, whether that's driving the disease or a consequence isn't entirely clear. And so for type 2 reaction treatment, again, this is probably what we spend most of our time managing in our clinic. These are patients that can go on to really require prolonged immunosuppression. We start with corticosteroids. That's a tried and true, but they often become dependent, and it's very difficult to wean them down. They have severe disease flares. And so we move quickly towards thalidomide. And so back in 1965, thalidomide was being used for its antiemetic effect in patients with Hansen's disease, and the ENL was treated very effectively with that exposure. So that was reported, and then in late 1990s, the FDA actually approved, this is like myeloma, ENL is an FDA approved indication for using thalidomide. Thalidomide is not available in every country. It's also difficult to prescribe to women of childbearing age in our country. And so better therapies and more available therapies are needed. That's led to a derivative search of phthalimid, which identified really two classes of derivatives. The class one were like phthalimid, targeted cereblon, and that was linked to the teratogenicity. Interestingly, while it had an anti-inflammatory effect, it actually was co-stimulatory to T cells. A second class, the target was identified as phosphodiesterase 4. And so the phosphodiesterase 4 inhibitor that's currently in use for psoriasis and Behçet's apremilast has been used off-label to treat this ENL. It's actually used a lot in India. And there are novel PDE4 inhibitors under investigation, some of which have been studied in tuberculosis, more to control the immunopathogenesis and sort of pulmonary sequelae post-TB. They seem to be effective. There's an ongoing trial in Nepal looking at PDE4 inhibitors that seem to be very effective to control ENL as well. And so novel therapies are needed, and if we can really understand the pathogenesis of this entity, hopefully we can identify better treatments. So some take-home messages, and hopefully we'll have some time for questions. I've shared with you that there's two etiologies for Hansen's disease, Mycobacterium leprae and leptomatosis. And while the transmission risk is low, we really do see more of this disease in certain populations to be aware of in our country. And it raises this question whether it's always endemic exposure, or if not just migration, but also these animal reservoirs might be playing a role in disease transmission is of interest. Two, that really the Hansen's disease is a disease of host immunity. There's very little diversity within the bacterial genome to suggest these are differences in the virulence mechanisms of various strains, and it's all about how the host responds to the bacteria. And so on the one pole where you have high Th1 and Th17, you have good bacterial control, whereas on the other pole, the lepromatous pole, you have more of an immune tolerant profile. And then we talked about the role for the PD-1 pathway and skewing that potentially therapeutically. We talked about two immune reactions, so mostly focused on the reversal reaction, these upgrading reactions. They are important in that they shift immunity towards bacterial control, but they lead to immune pathogenesis as well and require treatment. That's when you can get some more excess nerve damage. And then ENL or type 2 reactions, we discussed how there's a lot we don't know and how that might help us develop new therapies. So with that, I'll stop. I listed some great reads. If any of you are interested in learning more about Hansen's disease, there's only actually one nonfiction on the left. So this was written by an actual convict who was incarcerated in this white-collar prison in Carville, Louisiana. So interestingly, the National Leprosarium had a dual role for a number of years. It was kind of a white-collar prison as well as housing Hansen's disease patients. And this gentleman that was incarcerated there for kiting checks didn't know what was going on and really learned a lot more about the history, and it's a fascinating read. There's a number of novels as well that really go into more of the social aspects of isolation and stigma of Hansen's disease. So if you haven't read them, encourage you to look. And then if you don't mind providing a peer evaluation that helps us with an AID. I'll stop for any questions.